Iain Broadley, good morning to you and welcome to Word Sauce. Thank you for welcoming us in your location, I believe, in the United Kingdom. Could you kindly introduce yourself for our audience, please?
Well, good morning, and it's an honour and a pleasure to be invited on the podcast this morning. My name is Dr. Iain Broadley. I'm a Foundation Year 1 doctor working in the NHS, and I've been working on the front line since May 2020, just after the start of the pandemic. And my career as a doctor has only been during the pandemic, so it's been an interesting initiation into the workforce. I'm also the co-founder of the organisation NutriTank, which is a innovation and information hub for food, nutrition and lifestyle medicine. And I've been working, starting up NutriTank and building it into what it is today for the last 4 years. And I started at medical school.
So let's just take a little bit of a step back, because we've already used a word that can be a woo word in some environment, like lifestyle medicine. So tell us, what is lifestyle medicine?
I understand, some people might have connotations with it that are negative towards, scientific integrity. Lifestyle medicine is essentially using other forms of self-care and behavioral change, such as advice on sleep hygiene, exercise or physical activity, nutrition, diet, stress management, and social connectivity. And there are a lot of other forms as well. And using these pillars, essentially, and advising patients on changing these pillars for better health and management of chronic disease or any disease, really. I think some within the field maybe prefer to call it something such as self-care activation, because lifestyle can have connotations with that it's an individual's fault that they have maybe fallen into behaviours which are not great for their health. And we know very well that not all behaviours are actually created by an individual, but through societal pressures or where they've come from in their life. That's why they are choosing to take go for those behaviours. That's essentially what lifestyle medicine is, and there is fantastic published evidence now to state that advising patients on lifestyle medicine and factors of lifestyle are really improving their health and are leading to better health outcomes. And actually, although some would say that there is no evidence for it, it's interesting to see that the NICE guidelines, so the NHS UK NICE guidelines, so the clinical guidelines for healthcare professionals and doctors, the first-line management of many chronic diseases, from cancer, type 2 diabetes, heart disease, hypertension, polycystic ovarian syndrome, the first-line management is to offer patients lifestyle advice. But is that being done?
So the question, aside from the central matter, which is, will people do it and how can they do it? So that's the second issue. But the first issue that seems to be jumping is what's going on at the medical professional level, meaning what's the carer doing or knowing to be able to influence that aspect in his patient.
Well, yeah, exactly. Let's start at medical school. Within NICE guidelines, it states you need to be able to discuss diet and lifestyle. But even at medical school, medical students within the UK, the very varied amount of teaching on diet and lifestyle and how to talk to patients about, behaviour change and better diet. We spoke to a number of students across the years, and we've got published research on it now to show that as little as 2 hours of nutrition and diet is being taught within 5 to 6 years at medical school. So whilst I was at medical school, when I joined, I found out really, really early that within the lectures and within consultation skills workshops, we were not getting taught how to discuss diet and lifestyle. We were not getting taught the theory of how diet is, and better diet can lead to better health outcomes. It was quite puzzling why this wasn't being taught, because currently poor diet is the leading cause of morbidity and mortality around the world. And in the UK, it's one of the leading causes of morbidity. So the disparity between its importance and between what's actually being taught was it's really stark. So I met my co-founder, Dr. Ali Jaffe, at my medical school, and we found that we had a common interest in diet and lifestyle, and we were within the same nutrition interest group, and we got speaking over a year, and sharing ideas about what we could do to change this. And in 2017, we created the blueprint for NutriTank, which we wanted it to be a network of medical students across the UK, all organising educational events on diet and lifestyle, so that they could be educated for helping to improve their patients' health in the future, as well as knowing how to help, as well as learning the theory and practice to improve their own health and well-being. We also wanted it to be a think tank, so hence the name NutriTank, so a nutritional think tank. It's an portmanteau of the two words. And so we took a bottom-up approach, grassroots. We enabled students across the UK to start their own societies, and they invite expert speakers to come and talk at their events. And we've organised over 125, 130 educational events across the UK. We started off at Bristol Medical School. We then grew to 15 within a year, and now we have over 2/3 of the medical schools within the UK with a NutriTank Society. As well as a grassroots approach, we also took a top-down approach, and using our medical students, we gathered data on the current level of education and the number of hours they were being taught. We found that they were getting as little as 2 hours. Some medical schools get way more. So some medical schools get up to 24 hours. It's a real range. It's because every single medical school sets their own curriculum within it, but they have to abide by the General Medical Council's strict criteria. And we also asked doctors why or how much nutrition they were teaching. And the reason why doctors are not providing dietary advice in consultations is because they have a lack of confidence in providing it. It's not lack of time within the consultation. That was the leading reason why they're not giving it. So lack of confidence means lack of practice, lack of teaching. So that's really, it points towards that. So we took this, all our network, we took our research, and we presented it, and we were invited to the new nutrition curriculum that was being created, and we were invited to the working group, and we presented our findings at the working group, and we've now been part of the process of building a new nutrition curriculum for undergraduate medical students that's hopefully being launched in autumn 2021 for implementation within medical schools across the UK, with the hope that medical schools will provide the right level of nutrition and dietary teaching, so that when new doctors graduate, they are confident to provide dietary advice and know when to refer on to dietary experts. And why is this important? Almost 60% of patients arriving at hospital are malnourished or overnourished in some form. It's costing billions to the NHS, and it's not something that will be able to be changed with more pharmacology or with more invasive technology. So that's what. So NutriTank grew from a grassroots, and we're taking this two-pronged approach: grassroots and then top-down with the General Medical Council affiliated curriculum. But we're also created NutriTank as a hub. It's got a fantastic amount of information and resources on the website, and our social media always shares up to date dietary facts and news updates and all things that are going on within the UK within this space. So it's a very interesting place to come and find out the latest information. So just to go over a little bit more about what's happening in the UK in terms of the lack of education. In a medical school curriculum, you maybe get up to 5,000 hours of teaching. That's everything from lectures to contact time at within a GP practice. So 5,000 hours compared to only 2 hours of teaching on diet and dietary consultation. It's and the leading cause of morbidity and mortality being, diet and lifestyle. I think we need to, we all know, working within the space, that something needs to change. And NutriTank and its other organisations that we're working with are working very hard on changing that.
So what's been the reception? I sort of imagine that from the medical student standpoint, you've been very supported. People understand it. They probably want this for themselves as well. What has been the response of what I would say old academia or sclerotic academia in medicine, which can be very sclerotic and very backwards when it wants to. So how do they imagine this, as a thorn in their foot or as something that could be super amazing and that they wouldn't have to do because you're doing it?
Okay. To give you one, we've had mixed reception. So when we went to present to the medical school about why we needed more diet and lifestyle within the curriculum, we made a PowerPoint presentation. We were obviously very green young medical students, we were like second or third year, and we were able to be invited into a meeting with all of the academics and faculty, and we gave our presentation. And at the end of that, there was silence for about, it was probably 30 seconds, but it felt like 10 minutes. And we were basically grilled. It wasn't a fantastic reception, I have to say. It's it's not highly accepted or widely understood within maybe senior medical faculty. And I think the main reason for that is because of the need for more published data on the health outcomes from interventions. I think that's one of the main things, even though there are lots. But we were offered after that meeting access to meetings to create new nutrition within the curriculum at our medical school. So we did get change through that, which is fantastic. But we want, obviously, through the new curriculum more. So, and also there are those within the medical field who just do not want this at all. There is a lot of pushback, and there is pushback because of, is there evidence for it? And it's a very guarded field, obviously for good reason. But the time is now to, really change and innovate what really does need to be changed. We do actually have affiliation, and we're on a close coalition with an academic nutrition and medicine organisation and a couple of organisations where there are older academics within both the nutrition and medical field. So, we do have allies, but they are obviously a minority. So I think, obviously, you did touch upon a very important point, is the barriers to implementation. And we know that the best way to move things forward is for conversations and to understanding and listening and seeing why is it that they feel these ways, and what is it that we can do to say, actually, we understand and hear you, but what about have you thought about this? And actually, a good example is that we spoke at a medical, a very prestigious medical lecture, and there was a lot of older generation doctors in there. And one of the things that they came back with was, what about curriculum crowding? There's no space. But what we're trying to say is that actually nutrition can fall within every single speciality. It can be interwoven within the fabric of medical curriculum and within the medical field, so that it falls alongside pharmacology, biochemistry, surgical. So you get a lecture slide at the beginning of a lesson on cardiovascular disease. You get a lecture slide at the beginning of the pharmacology of type 2 diabetes. This is what causes or high risk of these conditions. These are the dietary factors. And then at the end of that lecture, when it comes to the treatment, you say, well, these are all the pharmacology, this is the surgical implementation, and also these are the factors such as diet and lifestyle. A slide on that. So this is the kind of thing we're aiming for, so that it is seen as the same importance and level as the other strands of intervention. So yes, a lot of pushback and a lot of barriers. We have discussed them in a paper. It was published in April 2020. It's called Time for Nutrition. And those barriers were discussed partly in that paper. And we've also published it in a recent paper in the in March 2020, with our insight into what we feel the future of medical practice could look like with dietary implementation and using the multidisciplinary team as well. We also don't think that it should just be doctors. It should be all, nurses, therapy teams, also with some knowledge as well. And it's not just about doctors, but we are focusing on one aspect to make sure that works as well. But we have a very broad network of organisations, and we're all working on separate. We're working with other organisations who are also working with nurses and other healthcare professionals. And within the UK, I have to say that our work is supported by nutrition and dietetic professionals and academics, and organisations, because they know that there is a gap and they know that there is a need. And these organisations are very academic and evidence based. So, we are collecting support and allies as we go along. It is just finding those barriers and really moving forward upon implementation. But there is change in the UK. I have to say that now, there are medical schools which are teaching cooking skills to their students, and whole year cohorts are being taught now. Since 2017, since we set up, there's medical schools which have increased their nutrition. There's medical schools which are teaching culinary skills and consultation skills and actually examining it. So change is happening slowly and in pockets. And what we are trying to do is find those best practices and link them all together to make sure that no medical school or organisation is left behind.
That seems like an enormous job, but a very worthy job. So the question that I have is a little bit problematic to some extent. Don't you think that, given your experience of what it was like to be at medical school and what it's like to practice medicine and how much self-care physicians apply to themselves, do you think there's an element there where when you're going into lifestyle behavior, maybe the sensation or the pushback is a non-conscious pushback, which is, do I need to become now also a guide? Do I need to become something that exemplify that which I preach? And it's not preaching that physicians do, and they practice medicine, they practice something, but the data is a problem. But the data is, as you said, already very, very significant. So the idea that the pushback is we need more data is something we hear in a lot of other fields within medicine that may not be justified. What do you think about this concept of how well are the healer themselves?
Well, yeah, no, a very good point. And I think that the medical field, it's evolved so quickly. Initially, being a doctor was about a paternalistic viewpoint where you were the healer and you fixed an issue. People would come to you, you'd fix an issue, and then you were seen, elevated, obviously within that relationship. But and then higher, the money and the drive has gone into more expensive interventions and pharmacology. But medical, especially in this country, I'm sure in other countries as well, it's evolving now so that it's not just seen as a paternalistic relationship whereby you're giving the care. You're actually, we're trying to make it a more balanced and level relationship where it's actually the patient or the client who is also actively being involved in that care as well. So public health and prevention is now becoming there's now a bigger emphasis on it, and so the role of the doctor is changing. Before, they didn't have to provide, or they didn't need to provide, or there wasn't that calling to provide that advice or provide motivational interviewing, but now there is, and so that's why it's being reflected back on the doctor now. What about your self-care? What about your own dietary preferences? So I think we need to split up into two things. One, is there a pushback because doctors now reflect what they're doing within their lives, or possibly? I can't answer for that, but I think that's really important for medics and all healthcare professionals to realise that you can't always be perfect within your own self-care, but that there is a balance as well. But it is so important for healthcare professionals, frontline workers, doctors, to know about this as well, because burnout within, especially within junior doctors. Do you know what it was over the pandemic in the UK? A third of doctors are reporting burnout in the last year. That's up from a quarter, I think. So yes, there may be a pushback because it means that they have to reflect on their own healthcare, their own self-care. But we think as an organisation that this is really, really important, that not only they taught nutrition for their patients, but also within that, they're also taught for themselves. Because we were at a presentation once, a public presentation, and someone asked, well, why are doctors now going to be giving healthcare, dietary advice? What about their own? Some doctors smoke, or some doctors do this. Yeah, I mean, this is the thing. Doctors are human beings too, and you have to realise that, and realise that, we also need to look after our own health and well-being. So important. Our branches, our nutrition branches across the UK, they've been organising yoga, meditation events, healthy lunchbox ideas, healthy meal kits, cooking skills. That's gonna help the medical student, hopefully, going forward. So it's both are paramount. The health of the doctor, and realising and reflecting on what they're doing themselves, before that they can go and help someone else. Before that they can help someone else, they need to be able to reflect on that.
Absolutely. I think it's the metaphor, somewhat overused, of the oxygen mask in the aircraft when the aircraft is going down, and if you have a child, you need to put it on yourself prior to be able to help someone else. But To a larger extent, what do you think the role of the larger society needs to play? Because I remember listening to the impassionate and really quite accurate and specific, a presentation of Dr. Malhotra in the UK to the EU Parliament on the food, including food inside the hospitals and the type of food that both patient and healthcare workers were exposed to within their work environment, and basically saying this needs to change. It's shocking. What do you think the role of the rest of society, the media, social media, engagement needs to play to help you out with this message?
I completely agree. Well, that is where this is where the issue stems from. It's from poor diet is coming from the wider society, and the mixture and the interplay between mass advertising, mass marketing, and food industry. So it's a lot to break down. Just to break that question down a bit. So we also work on. We also work with other organisations in sharing campaigns that they are working on. We are, as ourselves, we're working kind of solely on medical education. It's such a, it's a very big, complicated puzzle, trying to reduce the amount of dietary-related morbidity within, the UK or within Europe. Medical education and teaching doctors is one small piece of that puzzle. And so that's something that, is really important to say and focus on. But what we can do as an organisation is support other organisations and back up their campaigns through our voice as a collective medical student doctor network. So what needs to change? Completely agree. We need to have, better education from, starting very young within families on how to create a healthy meal from scratch within a budget. All of this has been lost over time and eroded within the UK, and its connection to food completely eroded away by modern day food systems and the incorporation of all the large organisations, large multinationals, which now supply our food chain. I'm sure that's very well written on why there is poor health. High fat, high sugar, high salt, reduced amount of dietary fibre, reduced amount of vegetable consumption and fruit consumption. But that's the thing, you can't really do mass marketing on a tomato on the same amount as a packet of crisps. So, the things that work are education and the things that work are bringing in better subsidies for healthier food and putting marketing and maybe, in the UK, there's this new watershed for advertising that for after 9 p.m. They're trying to stop or lobby or advocate for no junk food advertising until after 9 p.m. so that children are not always bombarded by it. And there's an amazing video by the campaign group, which was set up by Jamie Oliver, Bite Back. And it's a video all about how they got a bunch of teenagers. They picked them up in a taxi, took them to a restaurant, and at the restaurant they ordered a meal. And they recorded 3 of these teenagers, and they basically all ordered the same dish, and then they showed them back why they ordered that dish. Before they were doing this experiment on their phones, they got the social media advertising on this fried chicken. When they got into the cab, there was the same meal in the taxi cab on the thing. They were showing all these stages of where they were getting this advertising. They didn't even notice the advertising. But when they went to the restaurant, they ate the exactly same meal, and they were absolutely amazed by how this could occur. So it's an amazing and really interesting 5-minute YouTube. So I will share that with you, but it just shows you the power of mass marketing and for this type of food. It's fine to have this food within the context of once now and then, but when it becomes everything you eat every day, that's when issues arise, and it doesn't become nutritious for your overall health. So that's societal. These are the kind of campaigns that we're trying to back up and add our voice to. So this is the thing. These are the kind of things that need to change. And but then within hospitals, yes, the food there is really done on a very tight budget, and there is sometimes a lot of bureaucracy on where or what type of food can be implemented within it. And NutriShank has always been supportive of bringing in more healthier food for its staff as well as for patients as well. It is a very, very large but not non-solvable issue to increase or upgrade that food, that nutritious food. So let's just talk about vending machines, for instance. That we have ideas at NutriTank, working with other organisations to improve what can be offered. I mean, even at my hospital, it is after a certain time when the restaurant shuts, there is basically no nutritious food within the hospital, and it becomes a food desert. It is an issue because even if you're working, you're working 3 days in a row, you don't have the time when you get back home to create nutritious food. So you're basically stuck. With what you're offered in your environment, and I'm sure that kind of echoes how it is for a lot of people within maybe the UK when they're stuck in food deserts as well, with where they live. So we're working towards trying to improve what is offered within hospitals by supporting other organisations or other groups which are trying to implement this. So we are, as well as trying to educate medical students, and that's what we're focusing on, we're adding our voice, we're adding our advice, we're adding our support to initiatives to change things. And I think I've just given a couple of examples, but yeah, I think it's important to demonstrate that. So in a better world, in a perfect world, what do we want to see in the future? We want to see our food deserts to disappear, primary school, secondary school children to be connected to farms, be able to cook a meal from scratch, know what the names of vegetables and where they come from. That's being eroded. Free school meals. In the UK, sometimes a packet of crisps and an energy drink is what they eat for lunch, and what a lot of people eat for lunch. So that's where the baseline we're working from, and we're trying to improve that for a lot of people.
That's as you said, that's extremely worthy endeavor, and it's very badly needed as well. Now, you said something at the beginning which was quite unique, which is your experience in coming to practice in the middle of a pandemic. And although we've had viral epidemics before, I think this one of the magnitude that it has taken at the planet and the various forms that it has taken, none more severe than to healthcare workers who were frontlining this at the very early stage when we didn't know much what we were dealing with. So I would love to hear from you how much you've related this, your personal experience of going through this and having to care for patients, and at the same time, all the stuff that you knew in relation to nutrition and lifestyle behavior, and how these two things were either dichotomized or not, and perhaps share a little bit on that.
Sure. So when the pandemic started within the UK, I was a medical student, and I was in the last stages of my degree, and that had to end early. And then we were had the option of volunteering early to join our respective hospitals as an interim foundation year one doctor. So I took that decision, and I found myself within a couple of weeks helping out on the emergency floor where COVID patients were being treated and diagnosed. So, from a couple of weeks of, being a medical student and trying to practice what you preach, and then actually having the full force of a new professional job and your hours, a lot of your hours that you did have being taken away, and coping with obviously the stress and uncertainty of a pandemic, it did, obviously all hit me personally. I think it just took a couple of weeks just to reflect upon the fact that I was in a stressful situation. So I think I fell back on a number of techniques, or just a number of my own self-care habits that I try to make sure I do, and that one of them is connecting to nature, or another one is trying to create a large amount of food, nutritious food, earlier on before my shifts start, so that when I do go into the hospital, which at times becomes a food desert, I wasn't going to go hungry. And the other one was trying to take regular physical activity. So I think the dichotomy I'm trying to say is that it took maybe a little while to realize that I was in that stressful, reacting to stress. It can take a time to realize that you are stressed. And I think maybe something to anyone who wants to listen or is listening, that just reflection and listening to yourself is so important. So earlier on in the pandemic, we saw that that COVID-19 was really impacting more disproportionately those who were living with obesity, living with being overweight. And myself and my colleagues actually wrote to The Lancet, and we wrote a editorial letter on calling for the need for nutrition education for medical students, and that this disproportionate, there was a paper published within The Lancet on diabetes and endocrinology, and it was stating and showing how COVID was disproportionately, causing a lot of morbidity and mortality to those who were living with obesity. And we wrote an editorial to that paper and saying, there is a nutritional factor underlying this. This is the reason why there is a call for nutrition education. And I think also it was picked up, it was published. So it was published in August 2021. It's a very interesting read from The Lancet. But also at the same time, there was, the UK Prime Minister also had some time in the ITU or within a hospital due to COVID as well. And when he came out as well, he had a reflection and he realised, I needed to lose weight, and there was another call for action against, or action on self-care. The way it was perpetrated in the UK wasn't probably very healthy. It was a lot about lose weight, and we know that doesn't really work at all. So, the question is, is there the amount of people? Anyway, I think I've said all I want to say about that. So, yeah.
Understood. It's a very tricky topic. Let's put it this way, and we wouldn't want to endanger any of your position going forward. So, one observation which I thought, I don't know if it's still going on, but I thought at the time was kind of preposterous, was that the incitation to vaccine came with with junk food of any kind. And I know it happened in the US. I don't know how much it happened in the UK, but there were certain type of vaccines protocol where people were saying, if you get your vaccine, you get a burger or you get donuts, or
Wow.
we'll send donuts boxes too. So I guess it didn't happen in the UK, but it was certainly in the press in the US. It did happen, and I was really floored by by the combination of these two things. But anyhow, I think you're right in the sense that when I spoke with Dr. Lustig in the U.S. Prior to his publication of Metabolic, which I highly recommend, especially for a medical professional, it's a fantastic book on all the checks and balances and the pushback that a lot of other industries are giving to medicine. He did mention this concept of metabolical health was a big factor in the pandemic. And in effect, I think if I recall correctly, he said 8 out of 10 of US citizens are metabolically unhealthy. So you can imagine that when something like a pandemic occurs, you're not going to be in the best shape to face it if you're taking up to 5, 10 medications per day and your metabolic profile is a disaster. So how can going forward society, medicine, and perhaps even technology can be unified to take an approach to bring that with slightly less sort of barrage to it, which is the knowledge barrage, the scientific education requirements, the money barrage. How can these three actors play a role in helping people in their day-to-day lives?
Well, I think the main thing to realize, poor metabolic health, a lot of, and a lot of this, the language is used around weight and overweight and obesity. And here at NutriTank, we are trying to steer away from the whole weight stigma aspect of it. People who, are patients, they know, or they know because they have a lived with experience with it. They've had doctors and other people tell them that they are fat or overweight for many years and that they need to lose that they need to lose weight. So we are creating courses on how health professionals can understand how weight stigma affects patients. And I think this really does need to be highlighted. And we want to make this a really big issue within healthcare, and how negatively affecting it is patients. So we need to understand weight stigma. We need to understand that, yes, you can be overweight, but you can also be healthy at every size. So I think it is the messaging and it is the sensitivity about how you provide that advice to patients. So it's about saying, working in partnership with a patient, achieving goals together, or finding aspects of what they're, within their life, or what they want to change or why they want to change, the motivations behind that. So if you can distill what I've just said there, and then, increase the amount of nutritious foods that they can eat through education as well, and then marry that up with, technology. Let's just think, for instance, about some of these new apps that are coming out, behavior change apps, or is there a better way that we can use, digital systems within the UK, within healthcare within the UK, to link the two up, behavior change and digital health, to make a very big impact. I think the real focus does need to be on the personal interaction, getting it right at a small level before it's made into a very big thing digitally. Because if you don't have that lean startup testing, you'll find yourself with a app that doesn't work, that people aren't really using. And I can think of a couple in the UK right now which have been used for COVID, which aren't really working to the best available, compared to how much money has been put into it. So I think that's really important for any technology that is created in the future, that it really works on a small level, and it doesn't lose the human factor. And the human factor is a doctor or a health professional in that in that role as a mentor or facilitator for change for that patient. So yeah, I hope that whatever technology comes out in the future, it will have that human element of a facilitator of change for another human being in better self-care, so that it can tackle metabolic health. And I say that it's a quite abstract thing, but let's just say it, for instance, a patient who is drinking 10 fizzy drinks every single day, and they come to a GP or they come to the acute medical take, and you ask them within your medical clerking, as well as all the other aspects, what you do for a living and what medicine you're on, and take a history. You also ask about diet and lifestyle. You also ask, okay, so what's your diet looking like? And you find out they're drinking fizzy drink. Okay, how many? 10 a day. I think even if we can have that first aspect of reflecting, okay, do you feel like you're having too many, or have you thought about maybe cutting down to 1 a day or 2 a day? These are the micro changes that we need. And if this can be distilled into a technology, or if this can be done across the spectrum of healthcare, then I think obviously we will see change. I hope that answers your question, but I really think that any technology needs to have very much has to have a human touch to it, and not lose that.
Yep, and we're very near to losing that touch in even very basic technology now. So they're sort of redundant and they complicate things rather than help or simplify. So to conclude this wonderful conversation we had, the same question I ask my guests. So Iain, what's your weird sauce for life as a physician, as a young adult in a world, hopefully, that is soon to be rid of a pandemic, and as an entrepreneur?
So I think my weird source probably goes back to my childhood, my upbringing. I was quite lucky to have two parents who were quite adventurous, and a holiday was a camping trip on Dartmoor, which is a national park, which is pretty, I would say, quite barren to some, or a mountain, atop a mountain in the top northwest part of Scotland or in Wales. And I think that, during the pandemic, that reality of just being, in a hospital for the whole week, not seeing light or daylight, and feeling very confined when you come back home. When I had the opportunity connecting to nature or going for a walk and seeing that as a small piece of adventure, that really helped me to get through. Getting out, connecting to green space, and making sure you're having that at least once a week. If I'm sure in Singapore it might be harder, but you are very close to. I know you're very close to green space if you go a little bit outside the city. For me, that was really important. And the other from childhood, not losing that childhood need for adventure and doing things which you may have done when you were younger, playing a sport or any sort of activity. I would say never lose that. Never lose it because you feel like growing up you can't do it anymore. It's so important for human health and for my own personal health. I'm still doing or I'm picking up things as I go along: yoga, climbing, cycling, these kind of things. And even if you're just going for one walk a day, and if it's 5 minutes, that's better than nothing. Do not lose that. And the other thing is that just eating intuitively and trying to make a large amount of food, nutritious food, prior to a shift pattern starting, and taking that in good Tupperware for lunch or dinner for those days. That has really kept me going. That has not always been the case when you're working. Sometimes I run out, sometimes the time runs out, and you find yourself eating whatever's left in the restaurant or cafe in the hospital. And some of the food has been absolutely rubbish. So it is just reflecting. You cannot always get it right, and being okay with that, and being kind to yourself when it doesn't always go right, and when you go off track, and reflecting and saying, okay, I've gone a little bit off track. I can feel that my health is, or I'm a little bit out of sorts, and thinking, okay, these are the steps I need to take to that I enjoy and I know that are good for me and make me feel present and awake. So that's always what I go back to if I ever lose it. And I think the social connection, I can't stress this enough. The pandemic was probably one of the most unhuman aspects of whatever we've been through. Patients not being able to see their loved ones when they pass away. That was probably one of the toughest things. Seeing that, not being able to debrief with family or other colleagues, because when you leave the hospital you have to go home. So these kind of things are quite heavy on your mind as a doctor, and being able to process them. We were having whole wards of patients pass away within a week. That's almost 20 patients sometimes. That's very, that's something you have to deal with. But it is your job. But I think realizing and understanding how you process that. So never think that even if you're out on a video call, that is just as good for your mental health in terms of social connectivity as talking to them face to face. So a video call with a loved one, pick up the phone, have a video call with them, because that was also what helped me to get through many times through the pandemic as well. I can go on, but I think I'm just gonna leave it at that.
Dr. Iain Broadley, thank you very much for your time. We don't want you to be late for your job, very important job. Be kind to yourself, look after yourself, and let us know about your wonderful initiative and how we can help, perhaps from Singapore.
Thank you very much. Pleasure to be on.
If this conversation stopped you in your track, share it with your network. You never know whose life you might change for the better. Thank you for listening. Stay curious about our next guest, and stay curious about life.